All right, let's wrap up antibodies by talking about immunoglobulin isotypes. And here, the important thing to know is really the structure of some of these isotypes, and then when do we specifically see them in terms of their function. So let's start off with IgM, which is kind of like our base immunoglobulin, right? Because with IgM, if we have a T helper independent response, or this is a first response, usually it's IgM that we're going to see initially. Now, IgM can be a pentamer or a monomer. Now, classically, it's thought of mostly as a pentamer, and you can see an example of that down here. So you can see this IgM molecule, and you can see that there's all of these different binding sites here on this IgM molecule. So you can think of these as like individual kind of antibodies based on the antibody structure that we talked about before, and you can see that they're all linked to this structure in the middle here, and this link is the J chain. Okay, so that's going to be this linkage kind of in here, call that the J chain. Okay, so they're linked by this J chain or J protein, and again, if you look at how many antibody binding sites there are on one of these pentamers, you can see that there's 2 for each antibody, which is pretty much the case across the board. Every one of these antibodies is going to have 2 antigen binding sites, which means that a pentamer of IgM is going to have 10 binding sites, right? So it's going to have 10 binding sites for antigens. Now, the reason that's significant, if you think about some of your antibodies that are monomers, right? So, let's just say that you had an IgG antibody that already underwent affinity maturation for some antigen, and it's really strong binding, right? We've already had a response to generate this IgG antibody. And so we can say that this IgG antibody in particular might have a higher or stronger affinity for an antigen. Maybe it already had a T helper dependent response where we had a B cell that went to the lymph node and then underwent affinity maturation. And that B cell is now a plasma cell producing IgG to our antigen. And now we can say, okay, well, maybe this IgG antigen then has a higher affinity than that same IgM antibody, right? An IgM antibody with the same idiotype as this IgG might have a lower affinity. Okay, and this might vary in real life, but again, just for comparison's sake, let's just say that for those reasons, we have a higher affinity IgG and a lower affinity IgM. Where this gets tricky, where this comes in questions, you have to remember this IgM immunoglobulin has 10 binding sites for antigens. So it's got 10 binding sites for antigens. Now, if you compare that to IgG, IgE, IgD, this only has 2, right? It only has 2 antigen binding sites. So that's kind of tricky, right? So one has 2 and one has 10. So what we call this, we could say, look, even though this IgM immunoglobulin might individually, each one of these sites might have a lower affinity, right? So each one of these sites, so each one of these idiotypes here might have a lower affinity. Overall, the whole molecule, if we add up all of the binding from all of these individual sites, right, we might actually have an overall increase in its ability to bind antigens. And so that we would call the avidity, okay? So that's if we totaled up all of these different sites together, right? That would be the avidity, avidity, right? And so the affinity is we're just referring to that one site. And so we might say that this IgM antibody potentially might actually have a higher avidity, right? Because it has so many more binding sites as opposed to the IgG. Now, again, like I said, there's specific examples of this that might be different, but this is kind of a high-level way to just think of the terminology when they use avidity versus affinity. Okay, just cleaning things up here again, let's just recap some of this. So again, IgM, usually referring to the pentameric structure. Okay, we said 10 binding sites linked by a J chain. Early response to infection, that's what we just talked about previously in the last video, where we initially, that primary response is going to come out IgM initially. And again, when we have repeated exposures, we have a similar response on repeated exposures to the antibody serum concentration of IgM. We talked about that in the last video, okay? So go back and check that out. In terms of its function here, the primary functions of IgM are going to be to activate complement, and that's part of the reason for that is because it's so big, but remember, it also acts as a B cell receptor. So also, IgG is kind of the other big B cell receptor to be familiar with, and I feel like we've kind of talked about a lot of this already. Let's transition over to IgG now. So IgG is the most abundant immunoglobulin in the blood that's particularly high yield. Also remember, this is now a monomer. Okay, so we're talking about monomeric structure generally versus the pentameric structure typically of IgM. And again, this is going to be a little bit more of a delay in terms of its response to an infection when we compare it to IgM. Usually you're going to get your IgM being released first. However, if there's repeated exposure, right, you're going to get greater responses of IgG because a lot of that is going to come from plasma cells that have already undergone class switching. And so those plasma cells and memory B cells are going to be stimulated to have a greater IgG response. And that's why we use IgG for things like titers, like we talked about in the last video. And again, the big functions of IgG: also activating complement. We already talked about that. That's primarily going to be done in the FC portion back here, and opsonization also done in the FC portion. Remember, opsonization, there's two really big opsonins that you want to be familiar with for step one. IgG is going to be one of them, and the other big one is C3b, like we talked about a little bit earlier in the series. Okay, so complement C3b is one of the classic opsonins, and IgG also will do this. And the way that we're doing this is if we have some antigen that we're binding to, right, on the surface of a bacteria. So we're just going to draw a big bacteria here. Okay, so let's just say that, our immunoglobulin is bound to this bacteria. It's going to have a region there in the FC portion where essentially you can kind of pull in a neutrophil here. So maybe there's some neutrophil here, okay? And this region can essentially kind of lasso in the neutrophil to bind here and then phagocytose this bacteria. Okay, so that's what opsonization is. That's what we're talking about. And again, largely driven by IgG and C3b. Also, the IgG structure, like the IgM, both of them can act as B cell receptors. And we'll talk a little bit more about this coming up when we talk about things like hemolytic disease of the newborn. But the big thing you want to remember is that the IgG antibody, because look at how small it is, right? In general, it's a lot smaller than the IgM. And so for that reason, that's how you kind of remember that the IgG antibody can be transferred through the placenta from mom to the fetus. Okay, so what mom's doing is mom already has antibody. Throughout mom's life, she may have been vaccinated, right? She may have had multiple types of infectious agents that now she has a memory response to, and she has those IgG immunoglobulins floating around in the blood, and those can go to baby until those IgG immunoglobulins are turned over. Okay, once baby is delivered, mom's not going to be supplying IgG immunoglobulins through the placenta anymore. Okay, so initially that newborn might have some amount of mom's immunoglobulins that are eventually going to start to kind of come down during the first few months of life. And so how does that newborn continue to get some immunoglobulins from mom? Well, that would be through IgA, through breast milk. After the baby is delivered, right, through the breast milk, we can give IgA antibodies. And that's how you remember that IgA antibodies are associated with things like mucosa-associated lymphoid tissue, like Peyer's patches, or the mucosa of the GI tract. So again, classically in breast milk, also sweat and saliva, and IgA initially in circulation, it's more of a monomeric structure like this, but again, it's linked by a J chain like we saw with the IgM. Here's the J chain again to form a dimer once it's into the mucosa. These IgA antibodies, they don't activate complement. And one big pathology you'll see IgA come up a lot in is going to be, and there's a few of them, but this is one of the big ones, is celiac disease. Okay, and the thing that sometimes gets asked about in celiac disease, the classic antibody that you want to be familiar with is going to be tissue transglutaminase. Okay, so tissue transglutaminase, and sometimes they'll just write it as TTG. Okay, so tissue transglutaminase, and they'll sometimes ask you, you'll be like, oh yeah, I know this is for celiac disease, but they'll ask you which antibody specifically, which isotype is it? And it's IgA, right? Celiac disease is primarily affecting small bowel in general and absorption. And again, when you're thinking small bowel, when you're thinking mucosa, GI tract, you're thinking more IgA, right? So this is an IgA antibody. All right, let's jump down to the IgE antibody. So the IgE antibody, also a monomer like IgG. And the thing that you want to remember with IgE, there's two big things. It's really going to be its ability to respond to helminthic infections. So we're talking about worms, parasites. Also, its effects when we're talking about type 1 hypersensitivity reactions and things like asthma. We have a whole video on that already, so I don't want to go into too much detail in this video, but the concept essentially is, remember, you have mast cells and basophils that are housing essentially a lot of the histamine, proteases, leukotrienes. So let's just say that I have some mast cell here. Okay, so we're just going to call this a mast cell. Okay, so here's my mast cell, and this mast cell will have on its surface a specific type of receptor. We're just going to call it Fc epsilon 1. Okay, and it's not super important to know that, the exact name of all of these, but the point is that this receptor, like it says, it will bind to the Fc portion of antibodies. And so what do we mean by that? So hold that thought on the mast cell and let me show you. So now let's say that, we have some patient that had been exposed to ragweed pollen or bee sting or something like that. And initially, the initial response, they probably initially responded to IgM. Okay, so initially we might have had some, B cells with IgM receptors, for example, and let's just say that, this antigen bound to the IgM portion of this immunoglobulin. And what will happen is those B cells that have IgM on their surface, for example, that bound to this specific antigen might go and present this to a T cell. And they might undergo class switching. And so then what happens? And so then we start to make plasma cells that start releasing IgE antibodies through the stimulation of interleukin 4, like we talked about before, and interleukin 13. Okay, so now if our patient comes into contact with ragweed pollen again, or if they get a bee sting again, they have some plasma cells that are releasing IgE to our antigen. Now what can happen is some of these IgE antibodies can actually make their way and bind to the surface of mast cells. And look at how it's bound, right? So here's the Fc portion bound to the Fc receptor. And remember, this is your Fab portion out here. Okay, and now if we bind, remember we have the same idiotype as this IgM receptor because we went through class switching. And now let's say that we have a second exposure to the ragweed pollen, for example. So now, right, we're going to bind to that same region, okay, because we have the same region, we have the same idiotype. But now what happens is with these IgE antibodies on this repeated exposure, they're all bound to these mast cells. We might have a whole bunch of them here. And they can cross-link once they bind to their antigen. And that will stimulate these mast cells to degranulate. And so these mast cells, because of this binding, right, of the IgE receptor on its surface, now bound to its antigen and cross-linking, these will start to release substances, histamine being a big one, and leukotrienes, okay? So all of these will start to get released, and we call this process degranulation, okay? So the granules that are housing all of these structures are releasing them, so we call this degranulation, okay? So the mast cells will degranulate, release all these substances, and you can imagine if you have repeated exposures, right, you're gonna make more and more of these IgE antibodies, and more of them are gonna be sitting on these mast cells. So that's why if you're allergic to something and you get exposed to it multiple times, even if it's certain medications, can actually go down this route of anaphylaxis, because once you get to a significant enough amount of IgE antibodies bound to the surface of these mast cells and basophils, then what will happen is when you get exposed to that antigen, you're going to have so much degranulation that you can actually push this patient into anaphylaxis, okay? And so that would be the concern. This is a type 1 hypersensitivity reaction. We're hypersensitive to some antigen from repeated exposure. Now, in general, like we said, the IgE response is going to be particularly effective against helminths, and we can remember IgE with eosinophils, okay? And lastly on here, we have the IgD antibody, which is not particularly high yield in general. We won't go into too much detail on this. Just remember that it's a monomer. So the big things here, like we said, just make sure you're familiar with the different structures of the immunoglobulins, their function, and then any specific pathologies they're involved with. For example, IgE, we talked about type 1 hypersensitivity. IgA, we talked about celiac disease in breast milk. IgG crosses the placenta. Classic and opsonization, IgM acting in the early initial response, and then it's a pentamer. So just remember the key facts here. A lot of what's on here is a lot of what you have to know to distinguish some of these isotypes.